our first guest, Dr. Howard Rosen. Dr. Howard Rosen is a board-certified anesthesiologist and pain medicine specialist. He went to medical school at New York Medical College, and his residencies were at USC and UCLA. Doc, hello. How are you, Doc?
How you doing? Glad to be here. How's things in Florida?
Fantastic. Now, just give you a little background. Dr. Howard Rosen is also a teacher in the field of prolotherapy, and he's been at it a long time. I go to these meetings, and the doc is fantastic. He's there. He teaches his heart out, and I've learned a few things from him myself. Doc, can you, for audience out there who don't know what prolotherapy is, can you explain that to them?
Prolotherapy is short for proliferation. Basically, it's using a dextrose or a similar substance to create regeneration or to repair nerves for bodies. It's probably the most effective thing available.
Okay. Now, prolotherapy is actually dates back to 1,000 years ago. I mean, there's history that during Roman times, Hippocrates used to take a very hot stick, and when people were coming back from war, whether they were soldiers, and in fact, it's documented that it was a shoulder surgery that he would stimulate using that. Now, we've come a long way. Now, we have new material. What is some of the materials you like to use in your field?
Well, there are two. Dextrose is the standard. And actually, recently, I went back in history. I found information that almost no one knows, that the first injections ever performed in the 1800s were actually a form of prolotherapy. And they were using morphine. And I didn't believe that morphine was giving them the great results. So I researched it, and they were using glycerin with the morphine to mix it up. And now I'm using glycerin with really great results.
Fantastic. Now, there is a lot of new stuff happening. Tell us what's new.
Well, I do things that other people don't do. One of the things is I've come up with a topical formulation which has the dextrose in it, which I call Prologel, and that's one of the new ways to go, that you can actually treat people without injections, but mostly I use it to add to injections. So if they get a certain amount of pain relief with the injections, I add to that with my gel. Another thing is they're now treating nerves just below the skin with small needles. And that's someone's called neuroprolotherapy, and that's another treatment. And I've now used glycerin, which is actually paid for by insurance most of the time, and that's another thing that I use. Other people use platelet-rich plasma, and other people are using stem cells.
Fantastic. Now, do you see mostly men? Is your patients mostly men or women?
Well, the average woman will come to a doctor before the average man. So my practice is more women than men.
That's the same thing we're getting. What prolotherapy, does it help most of muscular, what is it that helps most? Does it help shoulder injuries most, knee injuries, or it helps all around, Doc?
Well, it helps almost any area, especially now that we have all these new ways to treat people. Musculoskeletal, or the muscles and ligaments, is important. Now we're starting to be more and more effective for arthritis. I find the newer ways, going just under the skin, that's been better. But I'm able to treat anyone from the top of the head to the bottom of the foot, and that's very similar to what other people can do.
Fantastic. Now, what is the age population that you get to do, and what type of patients would you say are they too old or too young?
Are they too old or too young?
What the patients that you're getting, at what age would you say they're too young or too old to get this procedure done?
Well, first of all, I never tell anybody that they're too old. As you get older, it's a little harder for things to work because all these processes, prolotherapy, is using the body to heal itself. And too young, I would start off with my gel when they get very young. Kids below 14 don't really like injections. So for them, I mostly use my Prologel. But around 14 is usually when they'll start to tolerate any injections.
Fantastic. Now, tell us how you got involved with prolotherapy yourself, Doc. Because I know you were an anesthesiologist, you're board-certified anesthesiologist. How did you get involved with prolo?
Well, I got into a car accident going for emergency C-section, and my neck really hurt. It was almost broken, and traditional methods didn't help at all. So I researched it. I went all around the United States, some parts of the world, and I was able to see that prolotherapy was able to help me. So I wanted to help other people, and that's how I got involved.
Fantastic. About how many treatments do patients usually need? Of course, that depends on their severity and the damage that they have, but on average, how many procedures does a patient usually need before they see good results?
Well, there are two ways to answer that. What I usually see with most of my patients is that 2 or 3 treatments, they're doing very well. If they want to get hopefully complete pain relief or almost pain relief, that takes longer. That may take 6 treatments. But most of my patients go for 2 or 3 treatments.
That's essentially what we get. Mr. Garcia?
Yes. Dr. Rosen, first of all, thank you for being on the show tonight.
Well, thank you for having me.
Dr. Rosen, prolotherapy is much more than just an analgesic treatment. It actually stimulates a biological reaction in the tissue that promotes tissue healing. Is that a correct statement?
That is correct. It is looking, though, that these days that they used to think it was like a stimulus to the muscles. It believes now it's more stimulation to the nerves. And, you know, all pain's carried in the nerves, and we're able to treat the nerves. The C fibers is what they're called. The body's able to heal itself.
And Dr. Rosen, when you treat a case such as an arthritic condition in a joint, when you do the prolotherapy, does it go in the joint itself, the meds or the substances that you use, or well, the prolotherapy, is it over the actual joint itself?
I'll go into the joint to get better benefit, and I also go in outside where the nerves are. So I usually go at both places for arthritis.
So, Dr. Rosen, is it correct to say that prolotherapy, the major tissue that you're trying to stimulate is the neurological system, the nervous system itself?
Yes, we believe most pain is neurogenic pain. The only reason that you hurt is because of nerves. And by blocking these nerves, you're able to have the body help promote its tissue healing. That's the current theory. I believe that's coming down right now.
There are several theories behind the pain. One of them is the ischemia that actually happens to the nerve endings. When the ischemia, or in other words, there's not enough oxygen that the nerve is receiving, the pain flares up. And certainly prolotherapy would play a huge role in these cases.
Exactly.
Yeah, yes, it definitely would promote that. There's even now one of the creams has histamine in it, which promotes dilation. So that's another way for it to work, most definitely.
And Dr. Rosen, is there such a thing as a patient that comes in with some kind of joint pain that it would be a contraindication to treat that patient with prolotherapy?
Well, if they have an active infection, I won't want to treat them there. So, and if they're pregnant, I don't treat them.
Yes, exactly.
So basically, in infection of the joint itself, that would be the only situation where prolotherapy would not be advisable.
And if the woman's pregnant. We don't know the results of that.
Yes, that's a good
Some
point.
people have used my cream on it, but I don't recommend it because we just don't know.
And does the patient usually respond after the first treatment immediately, or does it take a succession of treatments for you to get some kind of pain relief?
Well, it depends which kind of prolotherapy we're going with. Traditional prolotherapy, it'll take a few days to get a relief. With the newer form called neuroprolotherapy, they should be out of pain right then, within 5 minutes.
And Dr. Rosen, the difference between one and the other is the substance that you use for the prolotherapy?
It's where you put it. With the one that goes just below the skin, I use the dextrose, I use glycerin, and I also use my cream. For the one that goes deeper, I use dextrose just for that one.
And dextrose is the more traditional substance that's used in prolotherapy.
Yes, that goes back at least 60 years. A man named Dr. Hackett tried a lot of different things, and he found out that dextrose works the best.
Is there a theory of why dextro works so well with these, using it as a prolotherapy substance?
Yes, to be slightly technical, nerves carry pain, C fibers. The on and off switch for the nerves is called TRBV1 receptors. And the theory is that dextrose turns off the on and off, the dextrose turns off the TRBV1 receptor. And I have a belief, and I'm not the only one, that the reason it turns on and off is because it's supplying energy to this receptor.
I understand. And the C fibers are nerves that are located in all the joints of the human body?
Yes, they're all over. If someone cuts themselves, the first thing that happens, there are A fibers. And A fibers bring immediate pain. But the chronic pain, the reason it hurts afterwards, are C fibers. And that's what we're trying to treat. We're trying to treat, C fiber pain.
Fantastic. Dr. Rosen, for our audience out there that they love to do sports and they're very athletic, do you have any recommendations to prevent, to hopefully avoid any type of sports injuries?
Well, one of the things is don't keep doing some things if you're hurt. They say if the pain is a 4/10, where 10 is the worst pain, you need to stop that, and you need to not lift too much. Repetitions are much better than lifting one at a time. And for stretching, before I exercise, you got to do it for maybe an hour, but you got to do prolonged stretching. Just doing it for a few seconds, like I would do, isn't what works. They also say you need to get the muscles going, so you're actually best off to like jog a little before you do something more strenuous.
In other words, stretching is one of the best things to do. That's something we do recommend.
But you need to do prolonged stretching, not just, a few seconds of stretching. You need that joint to stretch much longer, like they do with yoga.
At least 2 or 3 minutes, right? Minimum of 2 or 3 minutes.
At least 2 or 3 minutes, and you need to do holds. And don't smoke. Never smoke.
That's right.
Obviously. Dr. Rosen, prolotherapy, should it be a first-line treatment, or should that be something that should be reserved for somebody who's gone through already all the treatment protocols and has not responded to the treatment?
No, prolotherapy should be much closer to first line. I mean, first line is not breaking the skin, heat, whatever. But after that point, I like prolotherapy before the other invasive techniques, steroid injections, that sort of thing. Physical therapy, though, could come before prolotherapy. But usually around 6 weeks, if you're not getting better, prolotherapy is what you need.